Toss it to you guys. All right, Kelly and Candy, take it away.
So I'm just going to say my name really quickly, and then I'll let Candy introduce herself while I pull up the slides. I'm Kelly Lemon. I'm a certified nurse midwife and women's health nurse practitioner. I work in Morgantown, West Virginia. Today I'm in Florida, which is fun. So I'm giving a lot of presentations on opioid use disorder today at my conference. So I'm excited to get to represent our people and West Virginia. So I'm going to let Candy do a good bit of the chatting today, so you don't have to hear crazy conference stuff in the background.
Hi, everyone. I'm Candy Cooley. I have a few different roles: the peer recovery support specialist, also the community health worker, and currently working on my certification for my prenatal, birth, and postpartum doula certifications. And I am with the ACE program, which is the Morgantown WVU site for the Drug-Free Moms and Babies program, which is throughout the whole state.
So out of curiosity, if you're able to hit your little like raise hand thing, or you can even just wave at me on Zoom, how many of you are familiar with the concept of continuous labor support or with doulas, or have heard of either of those concepts before? Oh, I got a thumbs up. Love it, love it. Got a hand raise, got a hand raise. They're throwing them up. Awesome. Okay, good. So my hope for you guys is that I didn't think it would be completely new information, but this is a really cool opportunity, I think, to see where we can build supports that we're already doing on both sides kind of into one piece. So really nitty gritty quickly, you're going to hear Candy, I'm going to assume, and myself also say things about like doulas, and we might use doulas and continuous labor support interchangeably. So the idea is that a doula is somebody who's going to provide some support, not maybe just labor. You'll see a lot of discussion about like continuous labor support and the benefits of it. So this is the idea that you're going to get a one-on-one person that's providing support to you. In labor, you can also do that prenatally and postpartum and in other facets of your life. The primary role of that person is to provide support. So the beauty of this is, while it might be able to be a family member, it is somebody that maybe doesn't have like so much skin in the game. So for example, can a partner provide support? Yes. Is a partner's emotions going to be all over the place and maybe they just want to be able to be in that partner role? Yeah. So this is literally someone having your back the whole time and they're just there for you. This person can provide education, they can advocate, they can do hands-on physical support, they can do emotional support. This can be a paid or an unpaid position. So I think sometimes we confuse labor support and doula service with a fee for service, and this can be something that's either paid or unpaid. Meanwhile, there's a doula. Candy, you're the expert on that. You want to tell us what a doula is?
Let me get myself unmuted here. Sure. A doula is a person certified for perinatal education and support. We get specific training and certification to provide support. Of course, we are allowed to begin working before we have that certification. That's how we get our certification, is we begin doing some services, hands-on services, before showing that we can have the certification, and having people sign off on it. Also with lots of other training too. So there's all kinds of different types of doulas. Like Kelly said, it's basically like a support person. So you can have abortion and miscarriage doula, prenatal labor. Those two things can kind of go together, or they can be separate services. In the one case that we're going to talk about, it's primarily a separate thing. And then the postpartum period, and those things, all three can be together, or like I said, they can be separate. There's also a death doula and lactation doula. And there's different certifications, different training programs, and there's like different types of certifications. All like for one position, there might be different types of certifications too.
And so that can be really confusing for people with all of the different certifying bodies. Again, this is not all of them. The top 3 that you're probably going to see as it relates to like the perinatal period and support are going to be DONA, International Childbirth Education, and Childbirth International. You do not have to be certified necessarily to be a doula or to do continuous labor support. The key thing with certification is that it does build in a level of being able to say like, hey, like this is what I can offer. This is like the standards that come with the certification. So for the consumer or the client, then they can look and say, okay, so I know that this is the baseline of what I should expect that your knowledge base is. This becomes really key when we look at states that are looking for Medicaid reimbursement or private insurance reimbursement. It varies based on the insurer. Some private insurances will let you use your HSA for this. Some will have stipulations on if they have to be certified or not. That is particularly true when it comes to the Medicaid model. That's honestly one of your biggest barriers to being able to get doulas in areas is getting over the cost associated with training and certification. And that's something that fortunately West Virginia is targeting and working on. So obviously evidence has to support anything that we try to get Medicaid to help us out with. In a dream world, we would be able to be like, hey, this is a really great idea. Can we do this thing? And they would go, yes, wonderful expert person working in that field. We believe you, but we do have to have our information to back it up, right? So there was a really great Cochrane systematic review that did show that continuous labor support can improve birth outcomes, not only for just the birthing person, but also for the baby. There are no adverse events identified with having a continuous labor support or a doula involved in your care. You can also use someone that's in your own network, and they found that can also be beneficial. While it might not show as much of a significant change in reduction of C-section and preterm birth, which we'll talk about in a second, you can still get a benefit out of it. And you might be asking like, okay, you're telling me about these benefits. What are they? Here they are for you, just in case you were curious. So we find that in addition to your regular nursing care, and that's something as me working in the hospital that I always see sometimes can turn into a little bit of a turf war. Sometimes my nursing staff and me previously as a nurse, I love providing that one-on-one care for my people. But in that nursing world, there's so many other things you have to do. If they're on a monitor, you have to watch the baby strip. You have to be charting on that. You have to be scanning meds. You have to be like giving handoff and report. You got to go cross cover your colleague while she maybe gets to go to the bathroom once every 6 hours if she's lucky. So you are stretched in a bunch of different ways. So even the most committed people that want to be in there the whole time, realistically, maybe can't do that one-on-one support. So all of these benefits are going to be in addition to your nursing care. We are not replacing our nurses or our providers when we're giving this care. This is a supplement. This is an extra. And also for any of my like nurses or providers, or even just like advocates of birth in the Zoom, they are not going to like steal your thunder and steal your thing. They are there to help you. You should use them. So we find that whenever, Candy, you unmuted, you got something to say?
Yeah, because I was just thinking, so my biggest thing, like, that I always like to think of is like, while everybody's doing their thing, mom wants ice. Who has time to go run out and get ice? Well, the doula can run out and get ice, so that's like, that's not something that like a nurse is going to have time to get, a bunch of women different little things. But a woman who has a doula, that doula can step in and just get the little weird things that, might help to give some comfort to mom. So just like Kelly said, it's a team, and, the doula is not trying to step in and do other people's jobs because a doula can't, so yeah.
Great. And a whole part of your doulas that go through a training is like, you are learning your scope and you're learning like what you can and you cannot do in that scope. So we find that when people have continuous labor support or a doula present, it decreases your need for analgesia. That's not just your IV medications, that's also epidural and nitrous. We have a decreased need for operative delivery across the board. So forceps, vacuum, and C-section, all reducing. And we all know that our state can work on decreasing our primary C-section rate. It decreases your labor. Who doesn't want to labor faster? No one's like, man, I wish I would have been a little bit longer. So it'll quicken things up. I'll spare you my huge rant. If you're ever curious about it, I would love to give you my rants on how we're all just like basic animals and what our needs are in birth to be able to like support that parasympathetic response to let your baby come out. So this one's a little bit wordy and weird, but it'll decrease your rate of a low 5-minute APGAR. So essentially our 5-minute APGARs are usually average to higher whenever you have this continuous labor support. And then increased breastfeeding initiation, which can also just help with bonding. It can help with your neonate like adjusting in that like transition phase as soon as they come out, which is probably where the improved APGAR score comes from. So lots of really good things. And again, we don't see any harms with this care. So only good things. Now, to touch a little bit again on the presence of formal training versus informal training, there was a really cool randomized controlled trial where they took 600 nulliparis. So for my non-OB people, that would mean somebody that's on their first pregnancy and their first baby. They were low income and they had a family member, friend, or support person learn some labor support techniques. Even in just showing somebody like hip squeezes and what to do and how to best serve that person, it improved APGAR scores. They had lower C-section rates and it shortened their duration of labor. So at a minimum, even if we're not going to put people all the way through like an exhaustive training and a doula certification for your areas where maybe there's like income barriers or reimbursement barriers, especially for our recovery community, if they have a stable support person, we can get a benefit if we just show them what those techniques are. And so there's a couple myths. And Candy, if you've got some myths that you've learned along your way, please dive in and briefly share them. I already touched on the doula is not replacing your nurse or your provider. We're not infringing on their turf. Laboring people are people. They are not territory, and we do not need to show up and like stake a claim. Me as a midwife walking in the room, I'm not like, the vagina is mine and the belly is mine and you can have the arm and you can have the thumb. We're not doing that. So we are all there as a team to help people out. Doulas are not just for home birth. That's a really common misconception that I get. I think if anything, they might be best served in the hospital setting. When you're in a home birth, you don't have to go other places. So the midwife attending that home birth like doesn't have other people that they're seeing. Whereas me in the hospital, if 5 people came in laboring, then I'm splitting myself 5 ways and I've got 5 people laboring. So doula is really well serving in those hospital settings, in those acute settings. Doulas are also not only for people who want an unmedicated birth. So by unmedicated birth, I mean, we're not going to get an epidural. I don't want any IV medicine. I want to do this au naturel, like we did in ye olden times, which is always great. And I love me an unmedicated birth. Some people are like, hi, I know myself, and that's not going to be for me. I don't do well with pain, and I would like interventions. Thank you. You can still have a doula and benefit from a doula. Candy, in your doula training, did they go over labor positions for people who have an epidural and stuff?
Yes. Yeah. And I think honestly, that's probably that and the home birth are probably the biggest myths that I have like encountered. And probably more so the medication one is a lot of women think that, well, people, think that, it's only if you want to have a natural birth, and that's not the case.
Right. And that's just like a thing where we need to, I think, improve education on just like birth all the time. Because I'll have people just as a midwife that are like, oh, well, I can't see you. I want an epidural. And I'm like, you can have whatever you want. So if I had to conceptualize, found this lovely graphic on the internet machine, you could easily trade out the person working as the nurse or the midwife back and forth. This is what your team should look like. So please note, no, we're not fighting over this person. We've got a whole squad. We've got their partner. We've got a doula or a support person. You've got your midwife and you've got your nurse. And if this wasn't COVID times, they would all probably have a very nice, happy smile on their face because we're all friends and getting along, right? This is the dream. This is what we should be having. And so you might be wondering, like, get to the point, Kelly and Candy, why are we talking about this as it relates to people with substance use disorder? So we know that our individuals who are in recovery experience a lot of stigma. They might have some impaired communication with the team. That might be just from misconceptions. That might be from fear. That might be from stigma. A lot of times when you look at qualitative research, they'll report that they did not feel heard or understood or safe. We know that our individuals in recovery are going to experience higher preterm birth rates. They're going to have higher incidence of low birth weight. That's partially related to the preterm birth, but also can be in our term clients. Decreased satisfaction with prenatal care, and then higher rates of postpartum depression. We know that there's complex needs. Candy, please interrupt me freely if you have anything else to add. If I see that unmute button go, I will shut up. We know that individuals in recovery might have an altered pain response. So childbirth can be an incredibly triggering time for anybody who has any kind of prior physical or sexual or emotional assault. Anyone who has a prior experience as a veteran might or has been in any kind of traumatic event, triggering events in childbirth. And isn't it nice when you have someone that can emotionally support you during that time that you feel safe with? They might have an increased need for pain interventions, and making that a little bit more complex is they might not be accepting of some of those. So I always try to make a pain agreement with individuals to see, are you comfortable with IV meds? Are you comfortable with an epidural? What's going to feel like it's a violation to your recovery, and what are you comfortable with? Because I don't want to make you uncomfortable in your birth. Contractions do that for you. You don't need me to add to it, right? They might have limited childbirth education. And maybe that's not, I'm not saying that like they have limited knowledge and education. The whole public kind of does. And maybe they're afraid to ask. We don't talk about it a ton as a society. I touched on a lot of these, so pain control and the childbirth experience can be really, really complex for them. So we know from other talks that we've had and other discussions that a peer is super helpful for people that are in recovery, right? We know that they have better outcomes if they have a peer and if they have support from someone in their community. They have better treatment retention and better satisfaction. And we know that the key characteristics of a peer is that they're going to give education, they're going to support them when they're vulnerable, they're going to advocate. You can have peers that are certified or uncertified. They're a member of the community. They meet people where they are, and it leads to better satisfaction and outcomes. And as I'm listing things off, my hope is that you're thinking, wait a minute, are we talking about doulas or are we talking about peers? And this is where I lead you to the crossover event, where I would highly recommend that what we get in the world are more peers that are working with individuals in recovery and that are providing that support. That would be just the absolute magic. At a minimum, if we can at least get these individuals like in contact with someone to give continuous labor supports or a doula, that's excellent. But for all of our peers that are working in the recovery community, this is a pretty intriguing model to me. So I really think that peers are a missing piece as doulas. And I know that there's a lot of training that goes into that. But I think it's magic, which is why I was incredibly delighted when my home slice Candy Cooley was interested in doing her doula certification, because I think that is a really magical piece. And so we just had an article that came out actually in a midwifery journal. I say we as in the midwifery community. I wish that I'd been on the ball on this first. Not cool enough, but you know who is this Megan Gannon lady. And so you can see down there a direct quote from the conclusions of this study that they did, in that when they did that mash over event, whenever they had a peer working as a doula, that they had much better outcomes, and that's a piece that we should consider. So Candy, I'm gonna shut up and I'm gonna turn it over to you. I'll bring up the case if you want, but before I open up the case, anything exciting?
No, but I think a lot of the stuff that you were saying when we talk about the case, it's really going to a lot of the stuff that, like, everything that you were saying was like, okay, this is in the case, this is in the case, this is in the case. So yeah. So do you want to go ahead and say the case, and then I'll put my part in?
Yes, that's what I was like. Do you want me to like hit the basics of the case?
Yeah,
so,
yeah.
So our person is AB. This person's 33 years old, is a G10 P3243. Very complex history, person that had a lot of trauma in their history. This pregnancy of itself was possibly a result of rape, and there was some uncertain paternity in there. This person's partner was periodically incarcerated throughout the pregnancy. There were different levels of involvement, and so we weren't really sure if this person was gonna have a partner present or not. Also a very sick individual, many chronic medical conditions that you can see listed there on top of having an opioid use disorder, many social history issues. So experiencing homelessness, there was limited mobility. This person did not have contact with her other children. And I think the interesting thing that you can see here is we also get this misconception that people only need a doula or a support person on their first baby. I think sometimes we assume that after you've had one baby that like, you know what to expect and that like, it's just, you just do it. And this person in particular had already had 2 prior babies prior to this birth. So this person was scheduled for induction of labor for all of our chronic medical conditions we had. We had this person in contact already with the ACE program. And then we also saw this person for treatment in our clinic. And it came to light that we weren't going to have anyone present with her at birth. And by it came to light, I mean, Candy, as she finds out all things in the magical way that she does, Candy found out that there wasn't going to be a support person for this individual.
So actually, I didn't find out that there was not going to be. So I came in blind, actually.
Right, I forgot. There was supposed to maybe kind of sort of be someone, and this person was like, "Oh, hey, Candy, would you stop by?" That was it.
Yeah. So she was lucky enough that she had someone help her to do a birth plan, and which is an amazing thing, especially for a woman who has, past trauma and someone who's dealing with substance use. It kind of gives you a little bit more of a sense of control of things and knowing what to expect. So she had a birth plan. I was one of the people on the birth plan to come in for support, maybe during labor. I mean, it wasn't like a definite thing. And the closer that we got, like it was a definite thing. And then the closer we got, the partner was going to be there and a supposed best friend was going to be there. And so she still wanted me to come in, but those 2 people were supposed to be the main people, and especially the partner. The partner was going to be like that main support person. And so the day that she let me know she was in labor, I kind of thought, okay, well, the partner's coming, the best friend is coming, I'm going to be like that third wheel. So, I'll come in. Well, when I strolled in, the nursing staff immediately was like, "Oh, she's waiting for you." No one had showed up. The partner didn't show up. The best friend didn't show up, which I have to say, with our women who are dealing with substance use, their support is not always stable support. We've had other times where there's been, a disagreement or something happens at the last minute with the partner, and then they're not there during the birth. So to have a doula be able to come in, and actually this case is what really pushed me to want to get my doula certification, because I saw how amazing, like, everything turned around. When I walked into the door, she was really, really struggling, really having a hard time. She said that they were not giving her anything for pain. And, the midwife looked at me and told me that they had given her everything that they could. They couldn't give her anything else. They had already given her fentanyl. She had already gotten an epidural. And she was in between contractions at that point, but she was so tensed up. Her neck was, and she was just, and you could see she was like not relaxing. Her breath, she was like holding her breath, and I could just see like the whole physical thing. So I had already had interactions with her before. Like Kelly said, she was part of our ACE program, so I knew her. And I kind of came in and I slipped my arm underneath of her neck and, just kind of rubbed her shoulder. And I told her, I was like, we've got to start relaxing your shoulders. We got to start. And she was like, they're not giving me anything for pain. I can't handle this. I can't do this. They're not helping me. And I said, honey, they are giving you stuff for pain. And I said, which I don't think anybody else could say this, but another, another person, another peer. And I said, honey, the fentanyl that they're giving you is not the fentanyl we're used to. I said, so, they have given you everything they can. And I knew the name of the baby. I knew the name that she had picked out. And so, and I told her, if they give you anything else, it's going to hurt. And I used his name. And I think that was like that moment where, and I was like, what we need to do is like, we need to calm down. I was like, and I kept rubbing her shoulder, and I was like, just relax your neck. And I was like, let's just kind of take a deep breath. And, and I was like doing it with her. And it was like that moment changed everything. She didn't complain about pain anymore. It was like normal, saying this hurts, but it wasn't like, oh, they're not giving me anything. It was absolutely amazing, the difference that moment made. She delivered, I don't know how long it was after I walked in, but it was not very long after I walked in. She did great in her delivery. Immediately began breastfeeding, had her skin to skin, began breastfeeding. The infant had some problems with blood sugar and needed to go to NICU. And so this was a really triggering point for her, as far as mental health and also for her recovery. That was like that another point where she was just ready to give up, and she kept saying she was going to leave, and she was going to, go outside. And I was like, you can't go outside. We have to stay here, and she was really, really upset that he was going to the NICU, blaming herself a lot. So, I just kept talking to her and, using the stuff that I had learned as, being as a peer, and stayed with her and made sure that she knew she had support. And she stayed in the hospital. She didn't leave. And she was ready to leave. I mean, it got to the point where she was banging her head on the window. She was really, really in stress. And this was like a really tough point for her. And for her to be able to stay in the hospital and get through that moment was huge. And I don't think that she would have been able to without having somebody there for support. So, that was really, the moment for me that, I have been in some other laboring points, but not there for the birth, like, stayed in for labor. And I've been there like immediately after the birth, and I've been there for support. And, but this particular case was really that one that like really hit home for me, that women in recovery, like the benefit of them having a doula is just astounding. I think that not only, for the, as far as like the recovery for the postpartum period, that's like a whole nother doula role, but that's also huge for women, especially women who have had some difficulties, like her having the baby go to NICU. It was just, huge. And I that was like really what pushed me to want to do my training.
And I think that as I kind of reflected on this person, she stands out to me as someone that really would have benefited from having a doula involved throughout the whole portion, because I know that like in the confines of when I had contact with this person for treatment team, like we have to be focused on like our medication and how we're doing in our recovery and all of those aspects. When I think about all of her chronic medical conditions, of this person going into prenatal care, for those of you not familiar with prenatal care, you are averaging 15 minutes to 20 minutes for a return OB visit. Sometimes if you're a little bit more complex like this person, you might get 30 minutes, maybe if you're lucky. And that's like, we're doing your vitals, we're doing your assessment, like we're going through all, so it gets really filled really quickly. And so I just think like, man, this person would have really benefited, even though she's had babies before, in understanding, like maybe no one's ever went over with her, like what happens in transition. So that phase that Candy walked into is that last bit, like right before you're complete and the baby comes, where everybody freaks out. Everybody. I've only had one person ever not freak out in transition. And I was like, you are a unicorn. And I feel really uncertain because you're not freaking out. This is someone that would have benefited from having that education, of saying, hey, like, because you have, and this also could have come up prenatally and should have, because you have diabetes, your baby has a higher chance of having a glucose control issue after it's born. It might need to go to NICU. This is not a failing on your part. This is just something that we might expect. And if that happens, here's what we can do to support you. A doula could have done that. That's not giving medical advice. That's just giving education. So I just always think of this person and how huge that could have been. Candy, the thing that I was also very fascinated with when this occurred, and then after your doula training, is there anything that you that you learned in your doula training that you were like, oh, that was that, or anything that you're like, oh, I wish I would have done this different?
Well, I really, I wish I would have known like pressure points. I really wish I would have known like, what more I could have done for her, like pain wise, and knowing how to help someone who's had an epidural. I didn't know that, and then like afterwards I was like, oh, that's, she was pulling her own legs up. So, and I, afterwards I was like, oh, that's why she wanted help with her legs. Well, I'm like holding her leg, but I didn't know she wanted her leg, like, all the way up to her chest. And she was doing that. If I had done my doula training, like I would have known, to ask her, like, is this what you want? Do you want, like I would have been able to like know way more than what I did. And I think too, like looking back now after doing the postpartum doula training, she could have really, really benefited in someone coming into the home, helping her with breastfeeding, you know, like the support that a postpartum doula gives after, you know, and just so that that person can go take a shower, or that person can go take a nap. And, you know, the doula can bath the baby, or, you know, just hold the baby, or do whatever is needed. She could have benefited from that so much, so much.
Sure. And I know that I told you guys I wasn't going to give you my rant on we're all fancy animals, but I'm going to give it to you now, because I think it makes you like make sense, because I know that I still, when I talk to people about this, they're always like, I just don't understand. Like, it's just like a person there. Like, I don't understand what the difference is. So the way that I always break it down for my people I serve in like clinic, or like my pregnant patients, is humans are very unique in that we're just fancy animals. So we have this like really complex higher level of thinking, right? It gives us memory, it gives us personality, it gives us like all these different like complex emotions and things. And it's really cool. We also have our basic human instincts and our functions. And when we talk about labor and birth, like physiologic labor and birth, and when you do an induction, the idea is that you are nudging the body, like, here's some medicine, start doing the process that you already know innately how to do. That requires, when you think about fight or flight response, you're like parasympathetic nervous system. So that is like the, like, I need to be chill and I need to be safe. And so when we think about with people, we put you in these, like, if you're having birth in a hospital, you're in a weird place. There's weird bleepity bloops on machines. There's weird people you just met. If you don't know what's happening to you, that's really scary. That's going to make you anxious. It's going to increase your cortisol. When we think about animals, all of you people, if you're from West Virginia, we all know, like, we see like cats and dogs and cows and everything. Think of a cat. If a cat's going to have a baby, is it going to go to a busy intersection in the middle of the highway, or is it going to go find a quiet little corner in a barn somewhere? It's going to go to the quiet corner where it feels like safe and it's quiet, right? Because it's like, I'm going to get vulnerable. I got to do me. I can't be like watching for threats. So I'm going to go to this quiet, safe place where I know that I can have my baby and labor will go. If things start like amping up, if your cortisol is increasing, our body doesn't know, is a bear coming after me? Or did this nurse come into your labs? So like, our body doesn't differentiate that. So if we think we're going to be unsafe, it's going to be like, halt the process, not bringing a vulnerable baby out here into this scary setting. So if we maintain a safe environment, if we keep it nice and chill, which is where your doula comes in, if you feel safe and supported, we decrease our cortisol levels. Our body tells us, I'm a cat, I can get safe here in this nice little barn and I can have a baby. So we are fancy animals, and that's where your benefit of a doula comes in. So for Candy, this person knew her. Candy's coming up in this space, even not having any formal training, coming into that space, being a familiar face, reminding that person like, hey, like, you're okay, we're going to get through this. All you have to do is breathe. Decreases that stress level, we decrease our cortisol, and it lets our baby come out. So even if you throw it in, there can be some benefit, but obviously a little bit more benefit if you have that extra like expertise to be able to provide education and all of those wonderful things. And so what I wanted to see, since we've got some good time left, is if anybody had any questions. I know there was some questions in the chat about how you can become a doula. Candy, do you want to speak to that since you went through the process? Or going through the process?
So I actually went through, I can't remember how many weeks my training was. But I went through, sorry if you're hearing my laptop just beeped. I went through the perinatal partnership. They were helping which they still are, they're helping the folks from the Drug-Free Moms and Babies for us all to get our doula training, which is amazing. And we actually had the opportunity to do the prenatal and birth was one. There was also a little bit of training for lactation. And then there was another separate one for postpartum doula training. And then I went on to do lactation support training. So, and that was all, done through the perinatal partnership. They kind of directed me where to go to the great people that were, certified instructors for this. And whenever you do your training too, they will give you specific instructions on what you need to do to, like, okay, you did your class. Now this is what you need to do for your certification. I saw in the chat, I just saw somebody say 3 births. And yeah, that was one of the things that for your prenatal and birth certification, you have to have 3 births. And then there are several books that you have to read. And in these births, you have to have, somebody from the staff sign off, and the parents sign off, and just say like what kind of job you did. And it, you have to turn all of this in, and like Kelly said, there are different certifications. Like I'm trying to do DONA. DONA is one of the biggest ones, but there are, other certification programs, but, so there's additional work besides just doing the additional class training.
Yeah. And so I know that a lot of the different trainings will touch on lactation topics. And so there are different trainings that'll go through lactation, but then you can also specifically do lactation consultant training. And that would be another thing. So you could become an IBCLC, which is where you would be able to say, I am certified and I can provide lactation support. But there are some doula trainings that are going to include lactation support also in there. Some embed an IBCLC in the training and some do not. I think the confusing thing with training is that there's a lot of avenues for training. So sometimes you'll find programs, and if you go, for example, on the DONA website, you can find like a link and like hyperlinks to different trainings. Sometimes they have specific like certifying body sponsored events. Sometimes you can have independent contractors or consultants. So let's say Candy finishes all of her doula certification and does this for like 15, 20 years. And she decides, I don't want to go out in the community and have these like crazy hours, but like what I really want to do is like train other doulas. Like Candy could like develop a training program, submit it to DONA, and then be this like cool, like DONA certified DONA training provider. So sometimes you can get consultants as well. There are some different, I had a thought and I lost it. Oh, there are different like training modalities. So you can go to in-person trainings, you can go to virtual trainings, you can go to structured if you're someone that's like, I need to be held accountable. I need this live Zoom session on this day. And there are some that you're like, my life is madness. I need to log in at my convenience and do this self-paced thing. So there are a lot of different modalities that you can do. Shauna, you are the queen. I saw you. I didn't realize you were on here. Do you want to talk about the West Virginia Perinatal Partnership doula wonderfulness? I'm putting you on the spot. I'm sure that's not what you wanted.
No, I was just trying to unmute. Yeah, hi, everybody. Yes, we got a fabulous grant from Unicare. It was actually $100,000. And then for the second year, they even added a little bit more money to it. And we have spent the past year or year and a half promoting and paying for doula training. And it is done by Robin Weiss, who is the president-elect of DONA. She has been training doulas for 25 years, and she has an online course. And not only that, she has office hours that anybody that's ever taken one of her courses can come to that office hour and talk about whatever it is that they need to know. So Denise Smith is my colleague, but we have all kinds of doula. I think that we've prepared maybe 60 now. and we have several in the pipeline. And some people know that, gosh, I can't just run out to a birth at 2 a.m. or 2 p.m. because of my life situation. So some of them have taken the postpartum doula training, and that was available as well. And so they learned that, they can schedule their time a little bit better to go and help these mothers. In the old days, we had, like, when I was having my kids, my mom came, and when my son's wife gave birth, yes, I'm the mother-in-law, but I was asked to come, and I actually slept with, don't tell the lactation people or the safe sleep people about this, but she kicked her husband, my son, out of the bed, and I had to sleep there in this gigantic king size bed on one side and the baby in the middle on one of those little thingies. And she was on the other side, and I had to help latch that child. You don't have that anymore. Not that I'm advocating a doula sleep with a mom to, get the baby on. No, but what I am advocating is to have that support, someone who will hold the baby when you go take a shower or a much needed nap, do light housekeeping, prepare a meal, sweep the floor, do whatever like your mother, your grandmother, your cousin, your aunt would have done. You need that support. You need a lactation support. You need birth support. I spent many years as a labor and delivery nurse at Ruby. And before that, I was in the Philippines. And before that, I was at Broadus Hospital. But point being, you have to have someone there with you. You really need that. And before, like you, Kelly, I wanted to render that care myself because I'm a very good labor support person. I can push you in places that you never thought about. And, I wanted to do that, but you can't do it. There is a nursing shortage. Not everyone staffs to A1 guidelines, which is what they're supposed to be staffing to for nurses. Nurses have to, somebody has an emergency, a cord prolapse or something. Well, we're all running off to do that. And, you can't depend upon the partner or a friend to render that support. They don't know the specialty things, but they, their emotions are tied up. And so I like what you said. But anyway, point being too, is that we still have some money left. If people want to join up and decide to be a doula, just contact me. I'm at slively@wvperinatal.org. And I can get you into, we have a little application process that just lets us know what you are doing and your background and everything. The other thing I would like to point out is that we have Lamaze Childbirth Education Seminar. It's coming up, I think, next week, and you could train to be a childbirth educator. You don't have to be a nurse, but if you want to add that LCCE, the Lamaze Childbirth Educator credential to your name, that's available through the partnership as well.
Yeah, and so one of the things that I think we're hoping for, Shauna, or at least I know in the initial discussion of like doing this and applying for the grant, was to try to eventually get to where West Virginia Medicaid would want to reimburse us for this. So there are other states, such as Colorado, who have already instituted this. So they do have Medicaid coverage for doulas. And imagine that they have much improved birth outcomes among all the people that are utilizing the services. So despite the fact that we have a systematic review from the Cochrane database and that we have an overwhelming body of evidence in the literature, Medicaid is still going to be like, yes, but I want to see what happens in West Virginia before we pay for that. And so hopefully we can help that situation.
Yeah, and the hard thing, I think, for the project has been getting people out, to do their 3 births, because people are like, okay, I'm training. And then after the training, it's like, okay, gosh, what do I do now? People aren't knocking at my door going, hey, do you want to, be my doula? You have to throw yourself out there. You have to network with all the obstetricians, the nurses, call up the nurse managers, do whatever you need to do. You have to be kind of assertive to do that. So I know Dr. Baltiera is on, and I know that maybe he would like to have some doulas. So be sure and ask your people if they would like to have a job being a doula, because I'm sure that there are needs out there. But we have doulas in our, that we have trained all over the state, literally from everywhere. So that's a good thing.
This is Janine Bryle from the West Virginia Perinatal Partnership. And I'll just add that we at the partnership coordinate a perinatal payers meeting where the Medicaid MCOs and state policymakers and private insurers participate. And I know, Shauna, you and the next quarterly meeting is actually tomorrow. And I believe Shauna and Denise are on the agenda to talk about doula, which we've been talking about for probably ever since Unicare gave us the grant, right? Or maybe before that, right, Shauna?
Absolutely. I've been nudging them. You can't just throw everything out there at once. It's like plant the seed, water it, watch it sprout, and hope somebody doesn't step on it, and just keep nudging it up just little by little. So that's what we're going to be talking about. And Kelly, if you can send me a copy of your slides, I'd be really grateful for this.
I was actually thinking the same thing. Maybe Kelly and Candy could come to one of those meetings and do this presentation.
Yeah, that'd be amazing. Yeah.
So there, like
all this makes sense.
Go for it.
All this makes so much sense. Like in reality, which is not how doulas typically have worked. Is like who gets doulas, are people who are financially able to have doulas. But in reality, like this is what I kept thinking, like my whole training was like the people who need doulas are the people who have Medicaid, the people who don't have the means to have a doula. One of the things that Robin, when she does her training with everyone, she always suggests that you give back to the community and suggests that, if you, as you're working, you do have like at least one client that, maybe is not like a high paying, you can lower your payments for this person, or maybe take payments from them, or, set up something like a sliding scale or something. And I always think like, just, the people, not just financially, but, different ethnicities, like doula services are really, really needed in our state, to improve birth outcomes and, women's experiences with their pregnancies, and, tying it in with substance use is just like, it's like a no-brainer.
The magic combination. And yeah. I think that Candy, you did a good segue into what I was gonna say. So, which is perfect. It's like we work together all the time or something. So your private insurances may cover it. It completely varies, and people just have to call their insurance company and check. The unfortunate thing historically has been that the people that can afford to do doula training and certification, and the people that can afford to pay for a doula out of pocket, are typically your middle to upper class white individuals who are not having as bad of birth outcomes as are people with substance use disorder, our LGBTQIA population, any individual of color, especially our Black mamas in the state and across the country. And those are the people that we really need. So I am sending out a call that the people that we really need to be getting into these trainings are the people that are going to serve those communities, because we know those communities are best served by the people that represent them the most. Hospitals are now starting to open up to do observations. They were shut down for a good bit for COVID, and I know that they're starting to open up. So if you are interested in doing doula training or having a hard time with getting into your births, I would shamelessly make yourself some cheap little business cards and a little flyer, and you walk it right into your OB office and you say, hey, I need to do 3 free births to get my doula certification, offering my services. And that can be a really good starting point. I love when someone comes in and gives me like a card. I have a running list of doulas that I know, and guess what, guys? It's real short. I would love to add names to it. So you can help build that out if you just like network. I am happy to go to work networking on your behalf if you need it, because I love me some doulas. So please don't hesitate to reach out. I'm going to throw my email in the chat if you need me. And I'm going to shut up because we're at 1 o'clock.
Thank you both, Kelly, Candy, Shauna, all the information, Janine. We'll definitely put the info in the recap email to everybody, so everybody will have like the copy of the slides, email contacts, all that good stuff. Our next session is going to be on June 12th, same time, 12 to 1. So be on the lookout for more information on that. And the evaluation link will also be sent around in the recap. So if you have a couple minutes, please be sure to do that. All right, everybody. Thanks for joining. We'll talk to you guys later.